So I'm going to touch on a couple of the things that have already been said, so I hate for this to be somewhat repetitive, but I do think it's worth having some of those points driven home. From a perspective of an athletic trainer or somebody that's normally working with younger, healthier athletes, you know, shoulder arthroplasty is not going to be something that you hopefully see a lot of, but certainly there are patients that will come along that are post-traumatic or post-sport related injury or failure of prior surgical procedures that end up having to have something like this done, and many of them will have a desire to return to sport. You know, our population is staying healthier and staying more active, and even in the face of arthroplasty, be it hip, knee, or otherwise, they want to keep doing a lot of the things that they do. So I think it's going to become more of a topic and more of an issue. The incidence of total shoulder arthroplasty has certainly changed in the last decade or so. Part of that is because we've stolen some of the technology from hip and knee and some of the higher connected polyethylene components that last longer and show less wear. You know, that was clearly demonstrated in the hip, and we've taken some of that technology. In the past, shoulder replacement was really, the territory of the badly fractured or injured shoulder that was not repairable, and so we did a lot of hemiarthroplasties, and that's where we sort of cut our teeth in terms of learning how to replace shoulders. And in early 2000s, 2005, and so there was a reversal where we started to see fewer hemiarthroplasties and more total shoulder arthroplasties. And it's just, for the vernacular for that, a hemiarthroplasty is just replacing the ball with a stem into the intermedullary space of the humerus, and a total shoulder is that plus replacing the glenoid side. I'm not going to go through the anatomy because Dr. Gadd already did a good job of that, but suffice it to say, it is a very large ball and a very small socket, and it is very much dependent upon muscular stability to maintain that joint in proper alignment and give you proper function. So in the absence of having that muscular stability, and absence of a functioning rotator cuff, hemiarthroplasty doesn't work, and frankly total shoulder arthroplasty doesn't work. So that's a big part of whether or not these patients are candidates for having those things done. So the indications, we have osteoarthritis, whether that's idiopathic, post-traumatic, whether it's somebody that's had prior sports-related injuries or car accidents, and those are going to be the big comers. We have a lot of rheumatoid patients still, although that disease is changing with disease-modifying drugs. But there is a certain element of rheumatoid patients that we call them burnt-out rheumatoids. They're not necessarily in the inflammatory phase anymore, but their shoulders are shot. So they still need to have that done. And they carry with it a special set of circumstances that I'm not going to belabor you with. Then there's this chronic irreparable rotator cuff, and it's becoming somewhat syndromic. I don't know if it's people that have had infections and Propionibacter is something that you're going to hear about. People are talking about it more and more in terms of whether it's arthroscopy or open shoulder surgery, and that can be a real bedeviling kind of a thing. And many of us are changing the ways that we're doing our anesthesia and our positioning, and whether or not we're using antibiotics and what kind of antibiotics to try and combat that problem. But you're going to see people that are going to have problems, whether it's breakdown of their repairs, what have you, and what do you do then? What are your bailouts at that point? Fracture, again, is still typically the realm of hemiarthroplasty unless somebody has pre-existing osteoarthritis, the rare case where you're going to have both, and then you're going to need to consider doing a total shoulder arthroplasty in the face of a fracture, which carries with it a whole other set of problems. And whether or not you do the regular shoulder arthroplasty versus a reverse. And there's some recent literature to suggest that the reverse in the face of bad proximal humeral fractures, 4-part fractures or more, may actually be better than trying to fix all those parts and do a standard hemiarthroplasty. And then finally tumor, which I'm not going to belabor other than to show you an interesting case. So this is a classic example of somebody, glenohumeral arthritis. Looks like they've got plenty of space over it. It doesn't look like there's anything fancy going on. Doesn't look like there was a prior fracture. There's no history of trauma here. This patient just shows up with a shoulder that's painful all the time. It hurts them during the day, it hurts them at night, it crunches, it grinds, it does all kinds of bad things, and they can't lift their hand up over their head. They can't really reach much beyond their belt line. Rotation is a real problem. They can get up here, but that's mostly scapulothoracic. This is what their axillary view looks like. So this is a great view to look for arthritis in the shoulder. because you can see there's a complete loss of the joint space. There's a flattening of the humeral head, and there's just no cartilage in there. Not a whole lot you can do conservatively for this, although some people will get by with an injection or two just to palliate them. And some people, frankly, they get to a point where they have arthritis, but they're kind of stiff and they're comfortable in their stiff place, and they don't need to have much else done. And so there's not everybody that has this needs to go on to have a shoulder replacement. Then you got a view like this on the right where it actually has got this huge osteophyte hanging down. This guy does not like rotation of his arm at all. He also has some crepitance. He looks like his rotator cuff is probably okay. Without an MRI, you can't say for sure, but certainly his glenohumeral alignment is okay. He's not riding high or anything like that. It looks like he's got a reasonably good joint space. And you look at his axillary view, and he's got some joint left there. It's not terrible. So some of those guys will do well with just a debridement. You just take out that big osteophyte, which is easier said than done, and they get a lot of their rotation back, not all of it. They still have arthritis in their shoulder, but they're much more functional, less painful, and that's, for the young person that wants to stay athletic, I think that's not necessarily a bad idea. We worry about, how well is a total shoulder arthroplasty going to hold up to a guy that's like this, that wants to continue with his martial arts. It's not just swinging a tennis racket. This guy's, rolling around on a jiu-jitsu mat. So what are we going to do with him? And then this, you can barely see the shoulder. It's totally surrounded by tumor. And what are you going to do about that? Sometimes you have to take the whole shoulder out and start all over again, but those are relative disasters. Clinically, these, again, patients show up, as I mentioned, with pain. Typically, they lose rotation first. It's almost always internal rotation they lose first, and then it's followed by external rotation, abduction, and they all have a little bit of crunching and grinding. Strength is usually only when they've been living with it for a long time, and you can get into some of those atrophy things that Dr. Dumas was mentioning before. Can also complicate what you're going to do. Somebody that's been really stiff for a long, long time and hasn't really used their rotator cuff at all, you wonder how good a person are they going to be rehabbing a total shoulder arthroplasty, and how much are they going to be able to do with that arm when it's all said and done, particularly if they have fatty turnover. It's hard to roll the clock back on fat atrophy. You can't just exercise that away, in my opinion. Imaging is relatively standard. We usually do plain x-ray, almost always do an MRI. It's in part because we want to evaluate the status of the rotator cuff. Rotator cuff intact plus minus can be a big predictor of whether you're going to do a standard arthroplasty or a reverse total shoulder arthroplasty. So we like to know the answer to that. CAT scans are usually reserved for those been chronically, in and out, dislocating many times, or bigger traumas where they may have had a glenoid fracture, and we need to know whether or not there's enough bone stock there to plant a new glenoid component into, or do we need to bone graft it beforehand. So I mentioned hemiarthroplasty. We still use this. It's still a go-to thing for people, sometimes with a two-part fracture, albeit rarely. 3- and 4-part fractures, much more common. I mentioned that if you don't have a functioning rotator cuff, this is a relative disaster. And there's been all kinds of things tried. Jumbo heads, heads that replace that part that would normally articulate with the acromion where it's not supposed to. None of those things are actually really great. Along comes the reverse total shoulder, and Goyer from France, was one of the ones that was popularizing the use of this for, chronic tears of the rotator cuff with rotator cuff arthropathy, and that's, I think, still one of the best indications for it, as opposed to somebody that just has a chronic rotator cuff tear without any arthritis, where there has been some studies looking at just replacing a otherwise totally good-looking shoulder just because the rotator cuff is not good, and I question whether or not the rotator cuff couldn't have been fixed in some of those cases, which I think would be a better option. But certainly in the irreparable rotator cuff, or the completely dysfunctional rotator cuff, that's become really the new standard. So just as some examples, 2-part fractures, they could be in the humeral head, they could be proximal humerus, but as a general rule, you let those hang for a while and they heal like gangbusters. Very rare to have them go to non-union, and you can always take them apart and put them back together with plates and screws, but that's pretty straightforward. 3-part fractures, well, frankly, they can also be treated non-operatively, particularly if you have an older patient with lower demand. Here you can see the head is off, the greater tuberosity is off, and then you got the shaft. But this one goes on to have a whopping amount of callus. There's not a great amount of motion there, but she's not a tennis player. She just needs to be able to do her daily hygiene stuff and Even though there was a little pseudosubluxation for a while, even that comes back just as the deltoid has to wake up. There's a little deltoid atony and you'll see the head drop out every once in a while. Just another example of that. The hemiarthroplasty, sort of an older version of the hemiarthroplasty on the left. We use these newer ones on the right where we can actually put bone graft into the prosthesis in an effort to try and get the lesser tuberosity and the greater tuberosity wrapped around that prosthesis, because again, we need to have a functioning rotator cuff, and that's where your rotator cuff is inserted upon in order for these things to do well. And as long as you can get a little bit of healing, and you can see actually both of these were able to heal the tuberosity back to the bone, they tend to do actually very well. And there's no replacement for the glenoid side. That's the metal against cartilage. And it does, I think, fairly well in the shoulder. It's not perfect, and some people will get some axillary kind of pain when the cartilage on the glenoid does finally start to break down, but we don't see a high revision rate to taking those apart and converting them to total shoulders. You do see that with hemiarthroplasty in the hip a little bit more, but I think that's because of the weight bearing. Total shoulder arthroplasty, again, I went through some of this, but as a general rule, it's just your osteoarthritis, whether it's idiopathic or post-traumatic. It's nice to have a patient that already has a reasonably good range of motion of the shoulder, has been using the shoulder so that we don't have to deal with some of those atrophy components. And many patients that have a standard shoulder arthroplasty can continue to participate in certain sports, particularly underhand sports. Golf, underhand tennis, bowling, bocce, any of those things they should be able to do with relative comfort. Some of the overhead sports I think are a little bit more difficult. It's not that they can't do it, but it has to be the right patient, the right outcome, and the moons have to line up, so to speak. Conversion to a reverse total shoulder can be done in those patients that have had a total shoulder who then become incompetent in their rotator cuff for some rhyme or reason. So there is a bailout. If your total shoulder goes bad, you can always go to a reverse. The problem is the reverse doesn't necessarily give you any bailouts. It is sort of the last common denominator. I think you got to give credit where credit was due. Charles Neer, Neviser, Flato, kind of in that order, have kind of popularized the total shoulder arthroplasty. Initial reports coming out in the late 70s, and many of these have been continued in showing really very good function and good relief of pain. And the studies demonstrate that also recently, in comparison to like total hips, the cost analysis is equivalent. And I mean, total hip is the gold standard as far as the cost it takes to put somebody through that. Surgeon's fees, anesthesia fees, hospitalizations, rehabilitation, the whole thing. It's really I don't remember the exact number, but it ends up not being as expensive as you think. And similar results have been demonstrated in the shoulder in terms of relief of pain and the quality of life. I think a lot of people will show up with pain in the shoulder, and you're like, all right, well, here's your pain in the shoulder. You got shoulder arthritis, and you got to go see the doctor and talk about a shoulder replacement. But I think it's really important. You got to examine these people a little bit more carefully. This particular patient has shoulder pain because of all the arthritis in the AC joint, and there's really no arthritis in the glenohumeral joint. Very different management for that. Again, you can look through the axilla and see that joint, looks pretty good, and it's just the AC joint that's a problem. Here's somebody that just sort of has your routine osteoarthritis. It's glenohumeral. There's not really huge osteophytes hanging down, but that whole head is like one big osteophyte. There's relative sparing of the space above the head, so the assumption is the rotator cuff is okay there, but do you really know? Because a lot of these people will have pain and weakness relative to pain. And so in many cases, we'll go through and get that MRI study to prove that that's okay, and they can go on to a standard total shoulder arthroplasty. The only way you can know that this is really a total shoulder, well, there's two things. I left a lot of cement hanging off the back of that glenoid prosthesis, but also that little metal line in there is a marker so that we know where the peg is inside the bone. So that prosthesis is cemented into the bone, whereas the humeral prosthesis is just press fit, and then we size match the head. And as long as that rotator cuff is okay, and we have to protect the repair of the subscapularis, which is what we open when we do our deltopectoral approach, so we have to protect for that external rotation, both in abduction and down at the side for a while. But these things they frequently rehab themselves. We would send a lot of these patients off to formal rehabilitation as long as they can get their motion back and start the strengthening process, and that's what the axillary view should look like, minus that big wad of cement in the back, which is, we go through the front, so it's actually relatively easy to leave a little bit of cement behind there, but Dr. Monica never leaves cement behind, so that's how you know mine's different from his. Reverse total shoulder arthroplasty is, again, the criteria are a little bit different, but the criteria are all over the map depending upon whether you're looking at some US literature or the European literature, which is a little bit, they have a little bit longer track record with it. But at the end of the day, it's severe osteoarthritis without really a functioning rotator cuff, whether that's rotator cuff arthropathy. You know, you could talk about people that have had nerve injuries. You can talk about people that have also had fracture associated with that. You could talk about the people that have failed prior arthroplasty within a standard way. Talk about the people that multiply operated on rotator cuffs, you know, whether it was infected or just tore more than once. Referencing those massive rotator cuff tears, the re-tear rate, depending upon whose paper you read, is as high as 20%. That's a big number in orthopedics. We don't like complicated rates that high, but I mean, those are all comers, people slipping and falling in the bathtub, little car accidents, tripping over the cords that are here. If you just had your rotator cuff repaired and you tripped over this mess of wires, you definitely re-tear your rotator cuff, and you have to do that over again. And you know, you can refix it. You can take it apart and put it back together again, but how many times can you do that and get away with it? The cuff does start to break down. You put a suture through it, it just starts to tear right through it. It becomes much more atrophied. So that becomes one of the indications for doing these things. Again, we have some limited long-term studies here in the US, and the European studies are a little bit longer, but as a general rule, it's a very successful operation, again, for preserving function. Not great function, but better than having nothing, and really good at relieving the pain. They're not really good options for a failed reverse. You can redo your reverse, but otherwise you're left with what we sometimes call a girdle stone procedure, where we do a resection arthroplasty. The joint is basically left open and you have a flail arm, and it's a fairly morbid procedure. But in those people that have had multiple infections, they've got a loss of bone, there's not enough bone stock to plant anything into, sometimes that's what we're left with. There's very rarely any ability to do any kind of fusion. One of the biggest bailouts in all of orthopedics is just to fuse a joint, and here usually not an option because there's just no bone to work with. Not going to read all the slides to you, but as a general rule, you know, these things have been looked at with, you know, really good results long term without really a need to do too much in the way of revisions, and some of them are relatively straightforward revisions in the sense you just got to swap the poly out, but the rest of the components are okay. I'm not going to go through a whole, you know, list of the complications and how you can put it in wrong or backwards or with impingement or all those other things, but there is a learning curve, needless to say, and we try and minimize the complications, maximize the experience. Here's an example of the rotator cuff arthropathy. So here you can see the humeral head's rotting high. It's actually touching the acromion. It's not supposed to do that. There's no rotator cuff there. You don't need an MRI to prove it. This is relatively mild cuff arthropathy, but you know, the x-rays don't necessarily tell the whole story. You got to treat the patient and not the x-rays. And people have terrible looking arthritis and really no pain and pretty good function. Leave them alone. Some people have not really terrible looking arthritis, but this shoulder can't move at all. This lady actually, I think, is more of a burned out rheumatoid without a rotator cuff. And you can see she's got some relative sparing of the joint surface on that axillary view, but she can't use this arm and it's killing her, and she's failed injections and therapy and everything else. So, and this is an example of a lady that actually has not had her reverse done yet, but she's had 3 prior surgeries for a rotator cuff, and it's just not repairable again. She's got some arthritic change, and so this is one that I would normally bring off for a reverse, and she's just sort of waiting in the wings. She's one of those people that we were talking about before. She hikes her shoulder, but she can get up to 170 degrees. She doesn't play tennis anymore. She rides her bike, and she can do that with the way her arm is currently, so they don't always go on to have fancy stuff done. I'm sorry, this is the patient that I meant to say was the burned out rheumatoid. So there's no real joint cartilage left there. She doesn't really have an active inflammatory disease going on, but I got an MRI of her shoulder that showed there was no rotator cuff here. And she hasn't really been using the arm. It wasn't really good motion of the arm. And again, those don't tend to do well with standard arthroplasty. So for all those reasons, I put a reverse in here, and you can see that we've put a ball where the socket used to be, and we've put a socket where the ball used to be. That lowers the shoulder a little bit, and it squares the shoulder a little bit, but it ends up being very functional very early on. They're wearing a sling for a very short period of time. They start Codman's protocol almost right away, and they move along fairly quickly. And she had immediate relief of pain, slept the best night she slept in years in the hospital the one night that she stayed over, and that shoulder has been fine. Interestingly, she has similar arthritis on the other shoulder, but here, rotator cuff was intact on her MRI, so that one gets a standard shoulder arthroplasty with the cement wad in the back. So she's got two shoulders, two different shoulders. One's round, one's square, but she likes both of them. She needs both elbows replaced and won't let me get near her again, so that's fine. Saw her yesterday, actually injected both of her, actually Thursday, injected both of her elbows, and she's going to be fine with that. As far as rehabilitation, most of these are going to be a year-long process, especially if you're trying to get somebody back to some activity like a sport, whether it's golf or whatever they want to do. It's not one of those things that we want to try and push and make them go faster. As a matter of fact, these fast actors or fast healers, that can sometimes be detrimental to the recovery, the overall recovery process. So it is one of those things you just have to sign them aboard and make sure they understand it's going to be a year, and one step at a time, and we'll get them through it. But they're not pitching for the Yankees in the next season. Most patients understand, but some need to be told that the motion is not normal. The arthroplasties don't lead to normal strength and normal motion, and frankly, they're not necessarily pain-free. I like to say less pain, not painless. So it's one of those things that you got to win patients over and set their expectations, and then your success rate with that goes up relatively significantly. I mentioned some of the precautions. Usually we're doing a delta pectoral approach, which is taking down the subscap, so we have to protect for that when we're rehabbing these patients. But once that's healed, you should be able to rehab that really aggressively, and they should be able to have good function of that. There are some patients that I do reverses where I go straight lateral, in which case we're just splitting the deltoid, and I think that's one of those reasons why those people go a little bit fast. We don't have to worry about waiting for that to heal. But not commonly done through a straight lateral approach. Some guys like it and some guys don't. It risks that axillary nerve that Dr. Gatt showed you. You're going to be right above that. And if you bag that nerve trying to do one of these things and you knock out the deltoid, well, the deltoid's the only thing making a reverse total shoulder work. So you've gone right out of the frying pan directly into the pit of the fire. So you got to be really respectful of that. We can't have that knocked out. Early goals, again, soft tissue healing. We want to get, if you had a muscle taken down, you want to let that repair. Then you have to strengthen the rotator cuff. They all go backwards. And if you want somebody to be able to return back to specific, especially an athletic thing, you've got to really focus a lot on rehabbing that rotator cuff. It is the key to their success at the end of the day. The other shoulder girdle muscles are not to be ignored, but they tend to take care of themselves a little bit better. The rotator cuff needs some specific attention. And so we expect a good functional range of motion. We expect a relief of pain. They should be able to do ADLs. And in the properly selected patient, return to sport is not, inconceivable, but we do tend to set some limitations in terms of the heaviest kind of activities, whether that be labor activities or sport-related activities. Thanks very much. Any questions?